Hello everybody, we were experiencing some technical difficulties via YouTube this morning. I think there's just lots of activity going on right now on YouTube. So we're recording this video that we'll post to the YouTube channel, and then we'll be back next week at our regular scheduled time for a live Q&A. I was mentioning earlier when we started the video that this information is not meant to replace your relationship with your physician. We look for your questions and we're happy to answer any and all health questions, but this is general information that you should certainly follow up on with your physician. I'm joined as always by Dr. Rita Ellithorpe, our medical director and founder here at Intestinal Longevity Center. And right before we lost connection, Dr. Ellithorpe was about to share with us some research that she came upon this week. So Dr. Ellithorpe, take it away.
Just a few days ago, there is a preprint, so this is not in a journal yet. This was coming out as a case report of a very, very ill patient, 54-year-old man who had a double lung transplant in Houston, Texas. And this is at the Houston Methodist Pulmonary Transplant Center, Houston, Texas. And he, unfortunately, on top of all of that, having the immune rejection and problems with that, got COVID-19. And what they gave, very interestingly, was an investigational drug called Aviptadil, Aviptadil, and its investigational drug reference is RLF-100. What is Aviptadil and why did they give it? The lung cells in the lungs are of two types. You have a pneumocyte 1 and then you have a pneumocyte 2. You have a lot of the pneumocyte 1s. They're the very thin ones that make up the little sacs called your alveoli. But the pneumocyte 2 is the one that's a little bigger and plumpier. There are fewer of them. They compose maybe 5% of all your lung cells. And they secrete the surfactant, and they create other things that are very important in maintaining the health of each little air sac. Unfortunately, it has the ACE2 receptor on it. Right. So when COVID-19 viral particles attach, they attach to the type 2 pneumocyte. And the type 2 pneumocyte is what helps make that surfactant, and it also gives birth, you might say, to other type 1 pneumocytes. So it's a bad scenario, because if it can't make the surfactant, you can't expectorate and clear your lungs and many other immunologically protective things. Well, Aviptadil investigational drug is a synthetic form, so it's a man-made form of something we know a lot about already called vasoactive intestinal peptide. This was first discovered in the gastrointestinal cells. This is a peptide secreted that has tremendous immunological function, and you would expect that in the gut, because the gut is the big first hit when you're taking in food all the time. Many pathogens and bad things could come in your diet as well. Right. And so God has put this wonderful peptide secreted by your gastrointestinal cells to help modulate your immune response. Now, given that it is an immune response modulator, and given that COVID-19 really does its damage through a overactive immunological attack on the lung cells and other parts of the body, producing hypocoagulation, microclotting, and so forth, they found that vasoactive intestinal peptide might be beneficial in this. So they tried it on this gentleman, 54-year-old, who had a double lung transplant, who was already having kidney and liver failure in a very bad situation, and he had already failed multiple other therapies. He was refractory to them. So they gave this to him, and interestingly enough, in 24 hours after the third infusion of this vasoactive intestinal peptide synthetic called Aviptadil, mimicking the vasointestinal peptide, he improved, his oxygen went up, and he was discharged home.
Wow.
So this is a case study. And I just thought it would be interesting for the patients to see the wonderfulness of research and why doctors really need to be scouring their journals and the science articles all the time. So this is a preprint. The author of the article is Jonathan C. Javitt, Javitt, MD, MPH. And yes, this is there is a financial tie to this and its success with a pharmaceutical company. But I think the results on this case study should be reported so we doctors can learn about it out in the field. There is another study that involved, I think, something like 45 patients with aviptidil, and don't quote me on this, but it was very dramatic, the improvement. I think 81% of them survived, whereas 17% in the placebo control group died from the acute respiratory distress syndrome. And if I can find that article, I will maybe bring that up next week.
Okay, interesting.
Yeah, isn't that interesting? And what I like about it is it makes sense when you understand.
Yeah, it's very creative.
Yeah, very creative thinking. And this is why America always leads with freedom when there is a capital interest, money driven, but if the drive is for a good thing.
It encourages innovation.
Innovation is encouraged.
Versus a more social medical system where you're almost discouraged from innovating because why take the risk?
Right, you won't make any profit on it, right? There was another article that now, and I'm bringing this up because the Journal of the American Medical Association published this October 30th. When was this published? This was just recent, also in the past few days. I don't see it right offhand where it was released.
Okay.
But again, we'll put this under, Blake, will you put this under there? Okay. This was October 30th, published by JAMA. And the title of the article is Peripheral Oxygen Saturation in Older Persons Wearing Non-Medical Face Masks in Community Settings.
Okay.
And why am I bringing this article up compared to the many others that I looked at? Because I find this interesting that a journal of the stature, allegedly, of JAMA would choose to publish this because there were only 25 participants, and they don't really give a P factor for statistical significance. And I just find it interesting that they would waste the space in JAMA to publish this article when I tell you the results. Now, it's a favorable article that took elderly kind of community nursing home participants, only 25. They set them in a pretty much equal male-female grouping. They did exclude people with severe ischemic heart disease, of which oxygen saturation at all times is very important. They eliminated those. But they did have other medical conditions represented, like high blood pressure, some respiratory bronchitis, some interstitial lung disease, asthma, cardiac surgery, but that doesn't mean known ischemic disease, diabetes, and former smokers who are on the usual medications you would expect for these things, including steroids. And they had them basically at rest, seated. They did a half an hour assessment of their oxygen, peripheral, O2 saturation, and they were all around 96%. Then they asked them to put on a mask similar to this, and they had their rested position for another half hour, and then they took the mask off again, and then they did the post half hour or hour. I think it was an hour, excuse me. And they sampled their O2 every 20 minutes, that's right. So essentially there was no big variation in the oxygen saturation of these average age 76-year-old male, female, 25 people seated, excluding ischemic, of which you can't afford to even mess around with oxygen saturation. And here's their conclusion. In this small crossover study, wearing a 3-layer non-medical face mask was not associated with a decline in oxygen saturation in older participants. Okay? Limitations include the exclusion of patients who were unable to wear a mask for medical reasons, like the ischemic heart disease patients. And it was investigation of just one type of mask. SpO2 measurements during minimal physical activity. In other words, some of them would have to get up and go urinate or something. So that's very minimal activity. So measurements during minimal physical activity and a small sample size. These results do not support claims that wearing non-medical face masks in community settings is unsafe.
Okay, so why are you bringing this up? What are you thinking?
I'm thinking they're grasping at straws to try and support mask usage in a normally considered a reputable journal, JAMA. So this is very unremarkable. This is very poorly set up population-wise. The N number, everything is just such a cheap, low-level, low-bar test. And I was just astonished that it would take the space of all the other things. For instance, the Aviptidil, one that I just talked about. There could have been much more. So I just thought it was a low bar, and they're grasping at straws to try and publish anything favorable about mask usage. Why? And that's because, almost 40 years of practicing medicine, I've always known that masks are really not the defense that you would hope it would be against viral illness or other things. It's just the volume of masks that have been studied from the N95, which itself is not a absolute protection either. Maybe it allows 5% of the size of the viron particle through, so it's not a complete protection. And then anywhere from a 20% to 85% exposure to the viron with these kind of masks. So masks are not our defense, never have been and never will be. And in fact, we do have studies. Why wasn't that published in JAMA, of that huge study involving thousands of people who were tested for COVID-19? I reported that about 2 weeks ago, where 85% of these patients who were always wearing their masks, 100% or very rarely took them off, were all COVID positive tested. Whereas only 3.9% of those who never wore a mask or rarely wore it out of thousands sampled. Now, why wasn't that in JAMA? So why isn't that commented on in their discussion here? There really is a poor defense for masks from a scientific point of view. All of history and medicine has not supported it.
Okay.
That's why I brought it up.
Okay. I have a question or two that I know came up, one through email and one before the live stream cut out. Should we go ahead and ask those?
Yeah. Mm-hmm.
Okay, so I'm going to have to paraphrase because for the question that came in before the video feed cut out. But the question was asked, what do you do if you test, and I think it was worded, if you test high for gestational diabetes, and they were referencing the glucose tolerance test that you take hourly, and then they measure your glucose levels. So what does that mean? What do you do if you test high for gestational diabetes?
Gestational.
Gestational.
Well,
that of course means you're pregnant. Gestational, right?
Mm-hmm.
Diabetes.
Well, we have such a prevalence of excessive eating cheap carb foods in America that we have a high probability of pregnant women today getting tipped over during their pregnancy into diabetes. Therefore, most probable OBGYNs are testing their patients with a glucose tolerance test. So there's a standard 75-gram glucose drink, and then they'll sample your blood every so often over a period of anywhere from 2 to 5 hours. And in that, if your blood sugar doesn't come down in a healthy fashion, then they're saying you have gestational diabetes. You might have come to the OBGYN with your pregnancy with a fasting blood sugar that still is under the highest top limit for a fasted blood sugar, but when they tested you, they found that when you're stressed, you couldn't really get it down.
Right.
So what do? You have to do what we've been teaching for many, many decades here. We're way before the low-carb keto craze is. You have to acknowledge that marketing, your social media, your Instagram, your church donuts every Sunday, these are damaging our health and promoting excessive triglycerides and obesity and all the diseases that are associated with these cheap, nutritionless, valueless carbs. So all you have to do is just eat healthy, low-carb lifestyle. So get away from all the refined carbs. Just eat your vegetables that are low. No, in other words, you wouldn't want to be eating the rice and the beans and the potatoes and the quinoa and the couscous. What you would want to be eating are the broccoli, spinach, asparagus.
Cruciferous, dark leafy vegetables.
Right.
Eat healthy fats.
Yes, eat your meat, your fish, your chicken, your beef. And that should help you.
And the developing baby, he needs those essential fatty acids and proteins, or she needs that the fats and the proteins, not the simple carbohydrates, not the sugars.
Absolutely. All of this is protein and fat.
Right.
And fruits and vegetables don't make your body. They provide micronutrients, okay? But you are composed, and the baby developing is composed of fats and proteins and some minerals. And the richest sources for these fats, proteins, and minerals are organ meats, oysters, lobster, clams, scallops, things like this, fish, chicken, beef, liver, poultry, and then secondarily the lower carb, high complex, fiber rich vegetables.
Okay. Great. So hope that answers your question. I also received a question via email to our email account, office@TLC Doctors, during the week. And the question was, this actually follows nicely with what we were just discussing. Can you give some recommendations for consuming more fat? I don't drink coffee or tea because I don't need to run up the walls from the energy. I saute just about every vegetable, or I add oil to my salads. I am more satisfied with fat, but still have hunger cravings. Thank you very much. And that's from Natasha.
Well, we have Parent Essential Oil as a liquid. And I have this little bottle of it. Blake, could you throw that bottle to me off there of the Parent Essential liquid? Yeah, just throw it over here.
And this has the truly essential alpha-linoleic and linoleic acids.
Right, yeah. And what I'll do is I will literally flip this and take a sip of this. And these essential fats are satiating. Fat has the highest index for satiation or suppressing your hunger.
Right.
I would also eat the skin on the chicken. In other words, I would not remove that fatty source.
Right.
I would not really trim the fat off my steak. I would have avocado in my salad. I would eat sunflower seeds, and nuts and seeds usually have good linoleic acid or are helpful. I would use raw butter. I would use the MCT oil in my coffee. You could get coconut oil and add that to your coffee. That's typically called bulletproof coffee. We have NT powder here. Blake, could you throw me the NT powder? It's right there. Just
And that's going to be your
Yeah.
phospholipids, your phosphatidylcholine.
Yeah, NT powder. This is fat, phospholipid fats, and you can mix this into your coffee.
Right.
We have jam-packed this into our doctor's great
Nutrition bar.
doctor's nutrition bar, and there is nothing out there that even remotely has the amount of healthy constructional fat that you're made of. In other words, you're made of these things. Your body needs this, your cell membranes. So those are excellent sources. Hopefully that helps.
And I always have my bottle of clinician's preference oils, the linoleic alpha-linoleic acid on standby. I have my NT factor powder with the phosphoglycolipids, phosphatidylcholine on standby. I have a big dark jar that I keep in a cool, dry place of my avocado oil, of my organic olive oil. And I drizzle my plates, breakfast, lunch, and dinner with that. It's whatever I'm eating. If I made up some taco meat that I'm putting on spinach, I'm drizzling it all over that.
Mm-hmm.
If I have a salad, if I make a smoothie, which I'm very careful about the carbs and sugar, of course, but we have some great medical foods here that are low carb, high protein, and have a lot of other great stuff in them. I add the NT factor powder, I add the clinician's preference, I add coconut oil to that.
Mm-hmm.
So those are some ideas. Hopefully that helps, Natasha. Some ways to get more healthy fats into your diet. Do be careful when you're cooking with fat that you're using oils that are have a very high smoke point. You like to cook in tallow or lard or butter, right?
Or coconut oil,
right? Versus like olive oil. You don't want to cook with olive oil,
or even avocado oil.
Okay, and so most of the vegetable oils.
Right. I keep vegetable oils on salads, cold and room temperature foods. The other ones are designed to not be oxidized.
Great. Well, I think that's about all the time we have today. This was not recorded live. We tried earlier and YouTube was just crashing on us, but this will be posted up. We did answer a couple questions in here, and we will be back next week. Hopefully everything works out for us nicely, and we'll be here at 9:45 a.m. Pacific on Wednesday. Join us, bring your questions, and do us a favor. Please be sure to subscribe to our channel and like these videos if you're enjoying this content. Share it with your friends and family. Thank you so much, and be well.